Thank you very much, and thank you for inviting me for this conference. I really enjoyed it. It's been excellent to see the kind of like the breadth of research that's happening across Europe. So I'll be talking about the Health and Occupation Research Network that I kind of inherited from some of my predecessors that have worked on this piece of work for now over 35 years. So this basically says the same thing, and also kind of like acknowledging that since last week I'm the deputy director of the Thomas Ashen Institute, which is also a great privilege. Another great privilege that I had in my career is to have worked with Malcolm Harrington, the person here at the lower end of this graph, who was professor of occupational medicine in Birmingham when I moved to the UK in the early 90s. And together with Colin MacDonald, another kind of like one of the giants in occupational medicine in the UK, made this kind of observation in the 1980s that actually routine statistics, although pretty useful, are not really kind of that useful in discovering new diseases, and that it's really kind of like astute, and they call it clinical observations. I probably think about it more widely because it's probably these observations can also be made by people who are not necessarily clinically trained, but actually observations in the workplace and of workers are really kind of important to kind of identify occupational hazards. And that's kind of the reason why this network was set up in 1989. So this network that we now call THOR, it had a few different names in its existence, stands really kind of like aims to collect data from physicians who see kind of patients and determine whether that disease or the symptoms that these workers present them with is related to their work. And we collect that data from these physicians and we use that information to kind of like identify trends over time, and also kind of like importantly trying to identify and report to the HSE kind of emerging issues. And these could be kind of new cases, new diseases, or it could be new trends or new clusters of disease. And so we now hold just about 130,000 cases of work-related diseases in this database that of 35 years. So quite a substantial database that we collected. So again, over the years, there's been a few kind of permutations about what type of data we've collected. So at the moment, we have 4 types of schemes, although the fourth one is probably kind of like on its way to be folded. But we're still collecting data from respiratory physicians, chest physicians, who report to us on obviously respiratory diseases. We work with dermatologists across the country who clearly report skin disease, and we work with occupational physicians who can report a whole range of diagnoses. So we don't restrict them to what diseases that they can report. And then I mentioned the fourth one that we established in 2005, also a scheme about the GPs to encourage them to report. And that is really kind of difficult to kind of to maintain because GPs are under so much pressure to do clinical work. So that's something that unfortunately I think we'll need to kind of pretty much kind of like discontinue or fall in with the OPRA cases. You can see that here as well. This is a graph of a table that kind of in the first kind of line shows the I don't know whether that. I'm not sure whether you can see that, but on the first line shows the number of reporters that report to us. So SORT we have at the moment, or last year we had 339. I think that's probably increased since then. For dermatologists we have about 100. OPRA, occupational physicians, 140, and then GPs, 108. Unfortunately, not all of those people kind of report to us. The other thing that you can see in this graph on this table is that core between the number of reporters. It says something like core and sample. So the core reporters are reporters that are reporting to us all through the year. So every month they send us a kind of a list of cases that they've seen. While the sample reporters, they only kind of like report to us 1 month on a month that's selected by us randomly, and we ask them to only kind of report to us the patients that they see with work-related disease during that particular month. Then the third line shows the number of cases reported during 2024, and you can see from the last column that we get very few cases from GPs at the moment. And it's unlikely that will be increasing. So from SORT, we have 221 cases that were reported to us of occupational respiratory disease in 2025, and that equates with an estimated number of cases of 475 when we adjust, because a number of these cases were reported by sample reporters. So we multiply, when we say estimated cases, the cases reported by sample reporters, we multiply by 12. Okay, and this is voluntary. We don't pay these physicians. So we need to really kind of make sure that the data that we collect is really kind of easy for them to do. So we ask them to report only a limited amount of information about demographics, the employment, obviously, where they work, what job they do, the suspected agent, what that causes the disease, anything in relation to sickness, absence, and patient referrals in relation to GPs. But the main things are what is the disease, some information about age and gender of the patients, and where do they work, and what caused that disease. This blue, we used to kind of collect all this information on the paper card and the physicians. We still have some physicians who kind of like want to report by filling in things in the blue card or the yellow card. But we really kind of trying to encourage people to kind of like report using kind of REDCap, which is a kind of like secure system that the university prefers when collecting kind of medical data. So I'll present a few kind of examples now of what we can do with this data. And I've got 2 examples, one around work-related stress. I kind of realized in the abstract I may have said dermatitis, but actually I changed that for stress, and another one about silicosis. So this graph is based upon the data that's presented to us by the occupational physicians. And this shows really the kind of like the relative contribution of different diagnostic categories that were reported to us from 1996 onwards to last year. And you can see this massive change, this kind of swap almost over from musculoskeletal problems that were the predominant diagnostic category in the mid-90s, where there was about 50% of cases was related to musculoskeletal disease. But that really has been taken over by mental health issues, and you can see now this yellow kind of area is kind of massively increased from about 10% in the early 90s or the mid 90s to about 60% of the cases reported by the occupational physicians is now related to occupational mental stress related to their work. So the others are kind of like almost kind of relatively declined, and the musculoskeletal is almost kind of like it's a kind of a mirror image. So now we have about 20%, I think, of cases are related to musculoskeletal diseases. We try to do some kind of fancy, sophisticated modeling of the trends of the these kind of reports over time, and this kind of takes into account the kind of reporting trends. So these are really kind of modeling within physician reporting trends, taking into account also the kind of like changes in the number of employees in the UK, etc. So you can see here that this increase over time from 1996 to about the end of 2008, 2009, and then it seems to kind of plateau and decline again a little bit. And there's two lines here. There's the line there in 2004 where the management standards were introduced by the Health and Safety Executive. And we cut it off by 2019 because 2020, the pandemic happened, and it's quite difficult to kind of like take that into account when doing these kind of trends analysis. But there is a clear increase, and there's a suggestion that maybe the kind of like, at least upon this data, that it has plateaued or declined, although that I think is not necessarily in line with self-reported data that is collected via the labour force survey. These are the kind of like the occupations that are reported to us that where these cases of mental ill health relate from, and they come from really professional occupations such as nurses, teachers, and medical practitioners, associate professionals, and administrative and secretarial kind of occupations. And you see here, if you look at it a little bit more refined in terms of the occupational code, there are nurses, teachers, administrative occupations, medical practitioners, and local government administrative occupations, which come out most often in these reports. Now, this is another kind of like one of these, I quite like these kind of stacked graphs with different colors. This one provides the relative contributions to the underlying causes of the reported mental ill health. And we're trying to map these causes to the management standards that I mentioned were introduced by Health and Safety Executive in 2004. And they kind of identify 6 domains. So demand, issues related to demand, issues related to how much control you have over the work, how much support they get by colleagues and supervisors and line management, relationships within the workforce, their role, understanding of their role, and organizational change. And so we're trying to map the underlying causes to these 6 domains, and it's it's a bit of a difficult chart to read because there's a number of combinations. But the first thing to see is that the bottom one, the brownish one, is where we couldn't really map the underlying cause to these 6 domains, and that could be either because the physician didn't mention it or the information provided wasn't sufficient sufficiently clear to link that to the domain, or it was something else. Now the other colors are the kind of light blue is demands, and then the green at a bit higher up is demands plus another. The orange one is relationships only, and then there's a I don't know what color you would take that, maybe burgundy is relationship plus another. Then the purplish one is change, and then the blue at the top is any combinations. And I think you can see from this that the demands, the kind of blue and the green color is a big contributor. So I think that's probably combined probably around 30-40% of the cases are somehow related to demand. And the other big one is relationships. So that's the orange bar. So that's another, I think probably between around 30% of the cases. So those are the 2 big kind of like contributors, I think, to the mental ill health reported to our schemes. So really kind of summarizing this kind of part is that, the OPRA kind of really confirms this kind of epidemic of work-related stress and mental ill health that happened since the mid-90s. There was a strong increase in those kind of earlier years, and then plateaued, and we kind of think from this data there may be a reduction. Data were only presented until 2019 because we're struggling a little bit to take into account the pandemic, and excessive demands and problems in relationships were probably the 2 dominant kind of causes of work-related stress. I kind of then I'll quickly kind of like go also on about SORT in relation to silicosis. So SORT is the work-related respiratory disease scheme where the chest physicians report to us. And we have a particular interest in silicosis, which is still a kind of a main problem that is still kind of like causing kind of like some issues in the UK and elsewhere. So in total, since 1996, we had about 315 cases reported to us, and I think immediately that says, well, there's an underreporting to the scheme. So we don't kind of like think that we have every case of silicosis or any other disease that's reported to us. So we miss quite a lot. We see an increase in the number of cases per year, and I'll come back to that in a little bit. And also we see that there's the average age has reduced in the later years, whilst the kind of like the over the whole period, the majority, almost all of them were kind of male. So this shows silicosis cases by industry and age. And I'm sorry, but you probably won't be able to read all of these, but it's basically giving from the left is ceramic work, brickworkers, construction, foundry, manufacturing, mining, other quarrying, stone masonry, tunneling, and worktop fabrication. And it gives the different bars, gives the age at which the diagnosis occurred. So the kind of, and I never know what color the color is, but these darkish blue is kind of less than 35. The orange one is between 35 and 45. So you can see the two that I've circled are the two kind of industry sectors where we see relatively young people kind of being diagnosed with silicosis. And that brings me to the reason for this, because following on from other countries, we have now started seeing cases of silicosis due to people working with artificial or engineered stones, which are used in kitchens and bathrooms, etc. And they're really, at least from the start, initially there were composites that contained a very high percentage of crystalline silica. And hence, particularly when they dry cut it, can cause a huge exposure, which can lead to kind of some kind of accelerated form of silicosis. And Chris Keane, who's in the audience, probably already kind of provided a presentation in one of the parallel sessions earlier about some of the work that HSE is doing around kind of measuring these exposures in the workplaces. So Joe Ferry, who's one of our reporters, kind of like reported on the UK case series a few years ago, I think last year maybe. And since then, we've seen a kind of increase of silicosis or cases reported to THOR related to exposures due to working with engineered stone. So we think we saw the first case in 2017. We've seen another case retrospectively in 2020, and then from 2023 onwards, there was this increase in the number of cases that are reported to us. Now, this is not because there's suddenly a kind of an epidemic. I think the reason why this is increasing so much is because Joe Ferrier mentioned earlier, and other physicians are now kind of actively looking for these cases. So they are kind of like, when they see a patient coming to them, they actually now actively trying to see whether some of their colleagues who may not have symptoms yet would be interested in come to the clinic and investigate them. So I think some of these may be unsymptomatic silicosis cases that perhaps, if you weren't looking for them, may not have been reported. So that's why we see this increase. But it's still a reflection of what's actually happening in the UK. So silicosis continues to be an important occupational health problem and is underreported. Increase in silicosis cases in worktop fabrication over the last 2 years, but that's partly or mainly because physicians are now kind of looking actively at these cases. And because of that, the mean age of these cases have reduced, and we see an increase in silicosis cases in our reporting system. So, summarizing at the end, I think we have a unique kind of database in, that we have established over this 35 years with medically verified cases where the physician have kind of attributed the disease to the occupation. Data is used by HSE to inform annual statistics, and we publish on these to kind of like try to, disseminate the evidence around trends in disease, around causes of occupational disease by age and sector and industry, and importantly also kind of identify sentinel cases. So we now have a methodology to review all the cases and identify cases of interest. Reporting declined during the COVID pandemic for obvious reasons, and we're currently working hard to get back up to pre-pandemic levels. And we're pleased to kind of like say that we received further funding from the Health and Safety Executive to continue with the SORT and epiderm schemes. So this is just a kind of acknowledgement. Obviously, all the reporters, we couldn't do it without their work. This is the kind of current THOR team that are working on this this project, which include kind of physicians, which includes kind of like research assistants and statisticians, and Raymond Aegis, who was my predecessor, who done a lot of work to kind of develop the THOR schemes, and all the kind of other members that have worked on this project in the past. So thank you very much.